Hello everyone and welcome to a clinical pharmacology and drug therapy channel. I am Dr. Khalid Hassan, professor of clinical pharmacology and drug therapy. In this session today, we are going to speak about three main topics, pharmacokinetic, pharmacodynamic, and pharmacogenomics. The pharmacokinetic will study the effect of the human body on the drugs. Pharmacodynamic study the effect of the drug on the human body. Pharmacogenetic display the variant response of the human body towards the drugs. When you have, for example, we have some genetic variation between individuals. In this case, we expect to see different response from those individuals. Our main topics for the today's session: pharmacokinetic. Okay, the definition here before we start in details, explaining terminology in pharmacokinetic and pharmacodynamic, pharmacogenomic. We need first to define what is pharmacology. Pharmacology may be defined as a study of the substance that interact with the living system. The living system here could be a human body, could be organs, could be cells, could be tissues. So here, again, the pharmacology is a field of study that study the substance interact with the living system through chemical processes, especially when talk about some regulatory molecules that activate or inhibit the normal body process. So we are going to speak about this process here, what we can use it, for example. So if you go to the pharmacology defined as substance, okay, I give example here, acetaminophen, paracetamol, brand name, another name, and the brand name Tylenol. This medication, acetaminol, used to relieve pain, used to relieve headache. Okay, so Tylenol, when you prescribe Tylenol orally, Tylenol will maybe go through the oral system to the gastric system, intestine, absorb to the blood, then from the blood will go to the brain, and from the brain will affect some type of local mediator. This local mediator called prostaglandin, and this prostaglandin, acetaminophen, Tylenol inhibit prostaglandin, and this will lead to relief pain. So now we understand we have mediator in our brain, prostaglandin, this mediator responsible for pain, and Tylenol arrive to the brain and modified inhibit this mediator and relieve the pain. So from the definition here, the pharmacology defined as the substance, study the substance that interact with the living system through chemical process. So you can see the chemical process there is like prostaglandin, and by binding, activation, or inhibition of the normal process. This is the most important things. We can give several examples here regarding the situation here. Another important medication regarding the interact between substance and living system. For example, we have warfarin. Warfarin is like a medication used as in general speaking as a blood thinner, but warfarin considered like anticoagulant medication and used to treat patients suffer from deep vein thrombosis, treatment and or prevention. Warfarin work by after prescribed it orally, arrive to the GI system, stomach, intestine, absorbed to the blood. Warfarin in the blood binding to the coagulation factors, inhibit these coagulation factors and prevent blood clotting. So now we can see here from the pharmacology definition, pharmacology study the effect of warfarin on the coagulation factors. What is the result? Prevent blood clotting. Okay, this is the first one. We're done with the pharmacology. Moving to another question here. What is or are the aims of treatment? Or what are the aim of drug therapy? Why we treat patient with the medication? Number one, to prevent disease. Number two, to cure disease. Number three, to control various type of disease. Another also, when you give example in this case, you apply the situation on reality. And when you have patient, you try to prescribe medication to prevent disease, to cure the disease, or to control the disease. Example here for the prevent the disease, we give the vaccine to prevent patient from infected by viruses or COVID-19, for example, coronavirus. We maybe give the vaccine to prevent from chickenpox. We give the vaccine to prevent from cholera, to prevent from, for example, tetanus. So we have several type of medication or vaccine substance to prevent the disease. Okay, cure here when you, for example, very popular example for a cure from disease, when the patient suffer from tonsillitis, infections, bacterial, for example, bacterial infections, we prescribe antibiotic to cure the infections, to cure the patient from the infections. This is number two. Number three, when you talk about control disease, control various disease, this is mostly applied for the chronic disease. Another example here, important example, when you speak about diabetes, we prescribe, for example, metformin to control blood sugar. So we don't have a cure from the diabetes currently, but we prescribe metformin to control diabetes. This is number one. We prescribe Ozempic or semaglutide to treat or control diabetes. Uh, Also, we can prescribe, for example, enalapril to treat or control hypertension. We don't have a cure from hypertension currently. Okay, so regarding control, we have a lot of examples here. The patients are from rheumatoid arthritis. We can prescribe methotrexate to control the disease. We don't have a cure from rheumatoid arthritis. I hope this explains the aim and purpose of the drug therapy. Okay, regarding the definition of pharmacokinetic and pharmacodynamic, pharmacokinetic refers to the study the effect of the body on the drug. What is the effect of our body on the drug? So we can say our body, human body, absorb the medication, human body metabolize the medication, distributes the medication, and eliminate the medication. So when you speaking about absorption, when you think about distribution, metabolism, elimination, these all variables belong to the pharmacokinetic. So pharmacokinetic mean absorption, distribution, metabolism, and elimination. So the pharmacokinetic is field of the study or that focus on the effect of the body on the drug. So what happened here? What our body will affect? How our body will affect the drugs? For example, we can say our human body will absorb the medication. Human body will metabolize the medication, eliminate the medication. This is a definition, simple definition for pharmacokinetic. Pharmacokinetic include four main processes: absorption, distribution, metabolism, and elimination. Moving to the pharmacodynamic, here we study the effect of the drug on the human body. So the pharmacodynamic study the effect of the drug on the human bodies. For example, this medication lower temperature, this medication lower blood pressure, this medication lower hyperglycemia or lower blood glucose, this medication relieve pain. So this is pharmacodynamic. Pharmacodynamic study the effect of the drug on the human body. So we have here some example. We can work together, me and you, to figure out which one belong to the pharmacokinetic and which one belong to the pharmacodynamic. Okay, so here the first one here, they said the human body absorbed the drug from the GI system. Is this pharmacodynamic or pharmacokinetic? Human body absorbed the drug from the GI system. Here our body affect the medication. This one considered like pharmacokinetic. Okay, human body metabolized. We have absorption here. Human body metabolized. You can see absorption with A. Human body metabolized the drug by the liver. Metabolize, metabolism, number two. Okay, then the human body eliminates the drug through the kidneys, elimination. So ADME, ADME, this is the abbreviation for the pharmacokinetic: absorption, distribution, metabolism, and elimination. Three main processes will be practiced on the drug. So the drug will be absorbed, the drug will be distributed, the drug will be metabolized, and at the end, the drug will be eliminated from our body. Okay, now what happened to so the first three here, if I clean this whiteboard here, the first three belong to the pharmacokinetic. What about the epinephrine increased blood pressure? Okay, should be pharmacokinetic. Study the effect of the drug on the body. So the drug increase blood pressure. Epinephrine increase blood pressure. Another name for epinephrine, another name adrenaline. Okay, Tylenol, acetaminophen. Tylenol reduce fever. Tylenol reduce high temperature. This is the effect of medication on the human body. Histamine cause vasodilation and skin rash. Effect of, so the last three here consider like pharmacodynamic. So we have here a very important definition: pharmacokinetic and pharmacodynamic. Again, pharmacokinetic focus on the study the effect of the body on the drug, that include ADME, absorption, distribution, metabolism, and elimination. Pharmacodynamics study the effect of the drug on the human body. So we can say, okay, this medication lower blood pressure, lower glucose, decreased temperature, and used for treatment of fever. Okay, the slide here give you the correct answer. As you can see here, the first three: absorb, metabolizes, and eliminates. So we talk about pharmacokinetic, as we discussed. We talk about pharmacokinetic, and the drug increase blood pressure, the drug lower temperature, and the drug cause vasodilation and skin rash. We talk about pharmacodynamic here. Okay, pharmacokinetic study four main process of the drug in the human body. Pharmacokinetic study absorption, distribution, metabolism, and excretion. So pharmacokinetic, I will repeat that, study four main processes that affect the medication. Study absorption, pharmacokinetic study distribution, study the metabolism of the medication, and excretion of the medication. So here the diagram here represent what happened to the medication when you prescribe it. For the patient come to the clinic and he suffer from pain or like headache, and you prescribe Tylenol, acetaminophen. So when you take the Tylenol will be maybe go through the mouth, esophagus, the stomach, intestine, and from the intestine will be absorbed. So we have gastrointestinal system where the drug will be absorbed. So of the drug absorbed, the drug will arrive to the systemic circulation, and what we mean here, the drug will arrive to the blood. Okay. Then when the drug arrives to the blood, the drug will be distributed to the tissues and cells here. The drug will enter tissues and cells. Okay. So then from the tissue and cell practice the effect, reduce pain. So Tylenol arrive to the brain and interact with the prostaglandin and relieve the headache, or relieve the high temperature, the fever. Okay, then what happened there? We have other tissues, other organ maybe involved in the effect of our body on the drugs. We have the liver responsible for metabolism. We have the kidneys responsible for elimination and excretion of the medication. We have other tissues, could be fat tissues, adipose tissue, and we have skin, we have the skeletal muscle. The end result will be the medication will be eliminated through the kidneys or other organ, excretory organ. So the drug will be eliminated through the body. So you can see here the process. The drug will be go through the oral, esophagus, stomach, intestine, absorbed, systemic circulation, distribution to the cells and tissue, practice effect, then eliminated through our body. So the question here we can ask ourselves, what happened if you give this medication instead of giving this medication orally? Another alternative option here, if we prescribe this medication IV. IV here mean intravenous. That means we inject the medication directly inside the vein. The medication will arrive, the total medication will arrive to the systemic circulation. The total medication will arrive to the blood. Okay, the complete medication will arrive to the blood here. So you can see here that we don't have absorption. So when you prescribe medication IV, we exclude absorption because the medication arrive directly to the blood. 100% of the medication arrive to the blood. Okay, so uh, we continue speaking about the pharmacokinetic. We have another important characteristic of the effect of the body on the drug. We call this one first pass metabolism. The first pass metabolism defined as the initial metabolism that a drug undergoes when it's absorbed from the GI system tract and passes through the liver before reaching the systemic circulation. So we are going to speak maybe defined or like stop for details for this concept here for talk about first pass metabolism. So this is initial metabolism. That what that mean for us when you talk about initial metabolism. We have like initial, we have like regular metabolism. Initial metabolism undergoes to the blood when the drug absorbed. So we have absorption. Then after that, from the GI system, for the drug absorbed from the GI system, the drug arrived to the liver, but before arrived to the systemic circulation. So you prescribe this medication. You prescribe this medication orally. The drug arrived to the intestine. Then from the intestine, the drug will go to the liver. Okay, from the liver, the drug will come back to the heart. Okay, the heart will bump the drug to the circulation, pump the blood to the systemic circulation. We call this process here, we call this process first pass metabolism. So you can see here the drug arrived to the liver for the first time before the drug arrived to the circulation. So when you prescribe medication orally, the medication will arrive to the intestine. The intestine will maybe move the medication through the portal circulation to the portal veins to the liver. In the liver we have metabolism, first pass metabolism. Then the drug will leave the liver to the heart, to the right side of the heart. The drug will move from right side to the left side of the heart, and the drug will be circulated through the entire body system circulation here. And as you can see here, the main location for the or the main organ responsible for first pass metabolism is the liver. The liver, the primary site for first pass metabolism. Okay, first pass metabolism here. When you prescribe the medication orally, the medication will go to the GI system, to the intestine, for example, to the stomach, intestine, and then the medication will leave through the capillary circulation, arrive to the portal vein. From the portal vein will maybe located in the liver. When we have the metabolism, this is the first time the drug will be metabolized. We call this one first pass metabolism. So if you prescribe 100 milligram from acetaminophen, for example, and this acetaminophen will arrive to the blood circulation 40 milligram, now we understand we have metabolism happened in the liver before the medication arrived to the blood, for example. So the medication now leaving the liver after metabolized and to arrive to the systemic circulation and then distributed to the tissues and cells. This is the first pass metabolism. You can see here the percentage here. So how much of this medication arrive to the blood. So as you can see here, when you prescribe 100 milligram of medication, when you prescribe 100 milligram of the medication orally, it's 40% of this medication will arrive. So if you prescribe 100 milligram, let me say this is equal to 100%. And 40% of this medication arrive to the blood circulation. We call this one bioavailability, the percentage of drug, the proportion of drug that arrive to the bloodstream. So again, for the first pass metabolism, as you can see here, the medication taken orally arrive to the GI system, from the GI system absorbed to the blood through the portal vein. The portal vein take the medication to the liver, where the drug will be metabolized for the first time. Then when everything done, the remaining of the drug, the parent drug, the active medication will leave the liver to the circulation, and from the circulation will distribute it to the tissues and cell. So we call this one first pass metabolism. Okay. So the question now from this example here, what is how much of these medication 100 milligram arrive to the blood? So when you prescribe 100 milligram, 40 milligram will arrive to the blood. This is an example. So the question here, what is the percentage? How much of this medication arrive to the blood? This is 40% of the medication. If you prescribe 100 milligram, arrive 40. That means 40% of the medication arrive to the blood. This 40% represent the bioavailability of the medication. The bioavailability definition, the bioavailability is a proportion of the drug that arrives to the bloodstream without change on the original form. So if you prescribe, for example here, 100 milligram acetaminophen Tylenol and 40 milligram of this medication arrive to the blood, so the bioavailability of this medication is like 40%. So the 40% is like amount of drugs arrive to the blood circulation without change, the proportion of the medication arrive to the bloodstream without change in the original form. Okay, this slide here emphasizes on important concept. Number one, they study the effect of first pass metabolism. They study the effect of first pass metabolism. Study the effect of first pass metabolism on the drug bioavailability, and we have the definition for bioavailability already. So bioavailability is the proportion percentage of the medication arrive to the bloodstream without change, unchanged form. So they said first pass metabolism normally decrease bioavailability. So you can see here first pass metabolism decrease bioavailability. It's when you prescribe 100 milligram of the medication and after first pass metabolism 40 milligram of this medication will arrive to the blood. So the bioavailability, the amount of the medication arrive to the blood will be less. Okay, decrease bioavailability of the medication. Number two, decrease amount of active medication reached to the systemic circulation. Yes, that's correct. Some drugs require high doses to alternative routes to minimize the effect of first pass metabolism. For example, if the medication destroy in the first pass metabolism, we need to try another route of administration, for example. So some drugs require higher doses as alternative route of administration, like intravenous, sublingual, to bypass or minimize the first pass effect. So we try to overcome the effect of first pass metabolism by choosing another route or route of administration. So again, first pass metabolism decrease bioavailability, first pass metabolism decrease amount of drug that reaches to the systemic circulation. In order to avoid that, we try to use alternative route of administration or use high doses. When you use high doses, there is risk of toxicity. Here we need to remember that. Okay, in practical example for us, we have nitroglycerin. And this nitroglycerin, this medication used for patients suffer from angina. Nitroglycerin, and normally we are familiar with that. Nitroglycerin prescribed sublingual under the tongue. So what they found there, nitroglycerin, if you prescribe nitroglycerin, if you prescribe it orally. So if you prescribe nitroglycerin orally, the nitroglycerin will undergoes the extensive first pass metabolism. 90% of the 90%, I will clean this one again. 90% of nitroglycerin will be destroyed in the first pass metabolism. In this case, we are going to have only 10% arrive to the circulation, and it's like absolute amount of nitroglycerin arrive to the heart, and it's not enough to treat angina or relieve angina or chest pain. So for this reason here we have nitroglycerin prescribed sublingual. So the question now, what is the purpose of prescribing nitroglycerin sublingually instead of orally? The main purpose, we have two main purposes. The number one, to avoid first pass metabolism. So the purpose of nitroglycerin prescribed sublingually, the purpose number one, to avoid extensive first pass metabolism. Number two, to achieve something called rapid action. When you prescribe it sublingually, the medication need 1 to 2 minutes to produce the effect. And this is important things here. So for we have the question now, we have the answer. Why we prescribe nitroglycerin sublingually? Because we're looking for rapid action. The patient suffer from chest pain. When you need it, we need to relieve the chest pain. Number two, and another important concept, if you prescribe nitroglycerin orally, nitroglycerin will be undergoes through extensive first pass metabolism and decrease activity of this medication. In this slide here, we tried to compare between oral administration, IV administration. Oral administration with 100 milligram, about 40 milligram will arrive to the blood, and this explains the effect of the metabolism in the GI system and the liver. On the other side, when you prescribe 100 milligram and IV intravenous, the medication will arrive directly to the blood. If you prescribe 100 milligram, the entire 100 milligram will arrive to the blood circulation. So the bioavailability for the IV prescribing will be 100%. On the other hand, for the bioavailability for the medication prescribed orally will be less 100%, could be between, let me say, between 99 to 1 milligram, for example. So it depends on the first pass metabolism. Okay, what is the definition of bioavailability? Bioavailability may be defined as a proportion, fraction, percentage of drug that reaches to the systemic circulation in unchanged form. Example for that, when you prescribe, for example, 100 milligram of medication orally and 70 milligram of this medication arrive to the bloodstream without change, this is, we call this one, the bioavailability for this medication will be 70%. However, we have some other factors. Some factors may affect bioavailability, such as drug physical and chemical properties, dosage form, route of administration, and first pass metabolism. Okay, speaking about drug absorption, absorption defined as a transfer of medication from the site of administration to the bloodstream. So again, absorption defined as a transfer of the medication from the site of administration to the bloodstream. They said the rate and efficiency of absorption depends on the route of administration. Okay, what that means for us, if you prescribe the medication IV, the absorption will be 100%. The entire medication will arrive to the bloodstream. The total dose of the drug will arrive to the systemic circulation. So this is the important issue here. If you prescribe this medication orally, this medication is required to dissolve in the GI system, penetrate epithelial cells, intestinal mucosa, and affected by different disease states and food and the GI system. So maybe we expect the medication to be lower. Okay, absorption of drug require drugs to pass through the biological membrane through several mechanisms of crossing. For example, the drug could be cross the biological membrane through the passive diffusion. The drug could be cross the membrane through the active transport or facilitated diffusion or something called endocytosis. So the four main process that give the ability to the medication to cross biological membrane: passive diffusion, active transport, facilitated diffusion, and endocytosis. Speaking about the drug passive diffusion, here the drug move from high to lower concentration. The drug does not involve carrier and is not saturable. The drug does not require energy from ATP. The vast majority of the drug gain access by this mechanism. Lipid soluble drug readily move across most biological membrane. Water soluble drugs penetrate cells membrane through the aqueous channels or like pores or fenestrated in the cell membrane. Okay, for the passive diffusion requirement, medication, in order for the medication to undergo the passive diffusion, as you can see here, the medication should be non-ionized, and in other words, we can say uncharged. The medication should be lipophilic. The medication should be in small particle size. The medication should be weak acid or weak base. So we have four conditions: non-ionized, lipophilic, small particle size, weak acid or weak basic. Example, we have aspirin, and another name for aspirin, salicylic acid. Aspirin is considered like weak acid, and it's uncharged in the GI system, especially we talk about the stomach and the first part of the intestine, duodenum, and this will allow aspirin to cross the cell membrane and arrive to the bloodstream. The second mechanism of drug transport through biological membrane facilitated diffusion. As you can see here, that the medication move from high concentration to the low concentration. The maybe requirement for this process, the medication involve carrier, transmembrane carrier, and this medication does not require energy. This is important one here. Does not require energy. Okay, so number one, from high concentration to the low concentration. Number two, this process require carrier. And number three, this process does not require energy. Example for that, transfer of amino acid, transfer of glucose. Example, as you can see here on the chart and the diagram, when you take amino acid through the food will arrive to the intestine. In the intestine, we have a carrier there, and this carrier is responsible for facilitated transport, allow the amino acid to cross the cell membrane and arrive to the blood. So you can see amino acid arriving to the blood through the facilitated diffusion. Another important example for the facilitated diffusion, we have glucose. You can see here, if you go back, you have the glucose coming through the food to the GI system. Our body will transfer the glucose to the blood through the glut transporter. So this glut transporter, so we need a transporter. Another name for transporter, we call this one carrier. So the same name, transporter and carrier. This is number one. We don't need energy or ATP, and the mechanism involve moving the medication from high to lower concentration. And two examples: facilitated diffusion, again, from high to lower, need carrier, does not require energy. Example: amino acid and glucose transport. Okay, speaking about active transport, here what they found, we have a few drugs may actively transported through the cell membrane. So we have few drugs actively transported through the cell membrane, and this medication. So we have few drugs that require actively transported across cell membrane using a specific carrier. So we need carrier here, and we need energy, ATP, and normally this transport happened against concentration. Okay, from the low concentration to the higher concentration, and this process demonstrates the saturated kinetic. So I will repeat: the active transport, very important. Active transport need carrier, active transport need energy, ATP. Active transport occur from low to high concentration and demonstrate the saturated kinetic. Okay, example for drug active transport, we have iodide and radioactive iodine or iodine. Iodide, they said when you take iodine, it's like 1/5 of the iodides ingested with the food are selectively removed from the circulation of the blood by the sodium dependent secondary active transport system. So you can see here the iodide, the iodide will leave the GI system to the blood, then will transfer to the thyroid gland by active transport system. So the iodide enter the thyroid gland, enter the thyroid cell through the active transport system. So in the thyroid cells, we have the iodine more concentrated 30 times to 100 times compared with the blood. So even with that, the medication moving from the blood to the thyroid gland from low concentration to the higher concentration. The same apply for the radioactive iodine. Levodopa is like a medication used for Parkinson disease. As you can see here, levodopa for Parkinson disease, for the treatment of Parkinson disease. The question, how levodopa arrive to the brain? You prescribe levodopa orally as a tablets, or for example, and then levodopa arrive to the brain. What is that? What type of transport absorption mechanism will the levodopa follow there? So after ingestion, after take levodopa orally, the levodopa will actively transport from the upper and small intestine into the circulation. So the small fraction of the drug reaches the brain after active transport across cell membrane. So as you can see here from the slide, levodopa from the slide here, levodopa here transport through the from the bloodstream, from the blood to the central nervous system. Here we have the blood through the active transport system. So levodopa arrive to the blood, crossing blood-brain barrier through the active transport system. When you say active transport system, we talk about mechanism, several mechanisms such as from low concentration to higher concentration. We talk about energy, ATP. We talk about the specific carrier and saturated kinetic. Vitamin B12 absorption, as you can see here, vitamin B12 does not absorb through the passive diffusion due to the large molecular size and require a specific transport system for absorption. So number one, the vitamin B12 is considered like large particle size. We need like specific intrinsic factors that available in the stomach. The vitamin B12 bind to the intrinsic factor in the stomach, then will be moving to the last part of the intestine and the ileum, where we have their specific transport system, and we call this system engulfing system, where the medication, where is this complex undergoes the endocytosis process and moving to the blood. Okay, regarding effect of pH on the drug absorption, most drugs are either weak acid or weak bases. Acidic drug HA, you can see here uncharged. When the acidic drug uncharged form release proton H plus, this is called a charged anion, A minus. The same will be applied, for example, when you look on the weak base P stands for basic, H for the proton. When the basic uncharged form binding to the proton, BH plus to consider like charged form. When this basic medication release proton become like uncharged. So you can see here when the basic medication bind to the proton uncharged, when the release the proton become uncharged. So when the basic medication bind to the proton become charged form, when the release proton become uncharged. The opposite will apply to the acidic drug. When the acidic drug binding to the proton, uncharged. When the acidic drug unbind to the proton, charged. Okay, this graph here, the last column here on the right side, you can see the acidic drugs such as aspirin, weak acid. When the weak acid binding to the proton H and become uncharged and able to cross blood-brain barrier through the proximal duodenum and arriving to the blood vessels. However, when this weak acid losing proton, this medication become charged. So as you can see here, charged medication unable to cross the biological membrane, unable to be absorbed from the proximal duodenum. So the charged form unable to absorb, the uncharged form will be absorbed easily. Practical example for the effect of pH on the weak base drug. We have diphenhydramine and the brand name Benadryl. Benadryl, diphenhydramine considered weak bases in alkaline environment, especially in the distal ileum, where we have in alkaline environment. With the alkaline environment mean that we have less acid, we have less proton. So in this case, the medication become uncharged. We don't have enough H, we don't have enough proton. The medication, the weak base will lose the proton and become uncharged, and therefore it will be easily absorbed. Okay, the graph here, the chart here represent the weak bases, the weak base medication but with the binding proton unable, the charge form when binding proton uncharged, when the binding proton unable to cross the biological membrane, the distal ileum, but when this weak base losing the proton and the weak base become uncharged, the uncharged weak base able to cross the biological membrane and the distal ileum and arrive to the blood vessels. Here we have some example for weak acid drug and other example for weak base drug. As you can see, weak acid drug, we have aspirin, then we have ibuprofen, naproxen, penicillin, we have methotrexate. So this medication considered like weak acid and mostly absorbed in the proximal, in the first part of the duodenum. Another example for the weak basis drug, we have list of medication for the weak basis drug. We have lidocaine, codeine, tramadol, cimetidine, diphenhydramine, amphetamine. So we have basic drug and we have acidic drug, weak base and weak acid. Most of the medication that prescribed orally, even weak acid or weak base. According to the weak acid and weak base, we have the equation between HA release or binding to the proton, BH plus releasing or binding to the proton. Okay, for the drug crosses cell membrane, biological membrane for a weak base, for the weak base, the drug, the uncharged form, the form with the considered B here, uncharged form which is considered B, passes easily through the cell membrane. However, the charged form pH plus cannot cross the membrane. On the other hand, if you look on the weak acid, the uncharged form HA can easily cross the membrane. However, the charged form A minus cannot cross the membrane. Okay, drug crosses cell membrane. Drug that is uncharged, typically the drug uncharged typically cross all cell membrane easily. So we need the drug to be uncharged. This is number one, or another name, unionized. Weak acid and will be absorbed easily, or weak bases. So weak acid and weak bases will be well absorbed. On the other hand, strong acid or strong bases tend to be poorly absorbed. So we need to remember that. So the most of the medication that absorb from the oral system, GI system, should be weak acid or weak bases. On the other hand, the strong acid or strong bases poorly absorbed due to the increased ionization and the physiological environment. This slide here demonstrate the pH, the acidic degree of the fluid in our body. For example, the gastric juice we have here, the gastric will be acidic, 1 to 3 pH, 1 to 3 acidic. The duodenum 5 to 6 is like weak acid. Small intestine, ileum, you can see 8 alkaline. So the large intestine 7.4, cerebrospinal fluid 7.3, the urine between 4 to 8. So we can create several questions. Okay, which of the following, for example, here organ which of the following organ has a acidic environment? So the acidic environment coming from the GI system. So you can see the GI system, gastric, the stomach has the acidic environment. Which of these organ system has the alkaline environment? So the ileum, the intestine, the ileum has alkaline. Which one of these organs similar to the blood? pH to the blood. So pH of the blood 7.4. So this one similar to the large intestine, to the colon, and again very similar to the cerebral blood fluid. On the other hand, if you look on the urine here, we have 4 to 8. 4 considered like acidic, and 8 considered like alkaline. So what happened here, that mean for the urine here, we can, as a human body, we can change the urine pH. So when you take medication, when you take any substances or food that make the urine acidic, so we can take some food or drink or medication, and this substances here make the pH acidic or alkaline. Okay, so for example here, if you give the patient, for example, bicarbonate, this make the urine alkaline. If you prescribe the NH4 ammonia to the patient, the urine will become acidic. So we have depends on the situation. What we have here, drink, medication, food, will change the urine from acidic to alkaline, or from alkaline to the acid, depends on the situation. We can manipulate, we can change of pH of the urine. Okay, practice question for the pharmacokinetic. We have a 63-year-old man recently diagnosed with hypertension. Started therapy with a hydrochlorothiazide, 1 tablet daily. Hydrochlorothiazide is an acidic drug. Which of the following part of the digestive tract most likely represent the main site of absorption of that drug? Oral mucosa, stomach and duodenum, distal part of smaller intestine, ileum, colon, or rectum. In order to answer this question, we need to ask ourselves which part of these tissues has an acidic environment: the oral, the ileum, the colon, the rectum, or the stomach and duodenum. If you say the stomach and duodenum has a acidic environment, you are correct. So the medication will be absorbed well in the stomach and duodenum. Okay, the second topic on the drug pharmacokinetic and clinical pharmacology pharmacokinetic will be the drug distribution. Drug distribution defined as a process by which the drug reversibly leave the bloodstream and enter interstitium, such as extracellular fluid and or cells or tissues. So what we have here, we need to be familiarized with the definition: the blood leaving the bloodstream to the cells and tissues reversibly. And we have several factors determine the drug distribution: organ blood flow, capillary permeability, binding drug to the plasma, and tissue protein. Okay, this chart here, this diagram presents when you give the medication to the patient, and this medication, such as IV injection or oral, the medication arrives to the blood. This is the blood here, the plasma here. So you can see the medication in the plasma available mainly in two forms: a free drug or binding to the proton. So the to the protein. So the drug, even to be free or bind to the protein, the free drug will be moved from the plasma to the cell and tissue. The question here: which type of drug will be leave the plasma to the tissues and cells? Free drug. Please remember that. So the free drug also will move to the fat for restoration. The free drug will be arrived to the intracellular fluid. The free drug will be arrived to the other part of tissues and cells. Okay, the important factors here maybe affect the drug distribution between these tissues: fat, extracellular, intracellular fluid, and other tissues. We have protein binding, permeability, and pH compartment and pH of the medication. Okay, regarding the organ blood flow, as we know that we have organs, some organs considered like rich in blood flow. They have more blood flow, such as brain, liver, and kidneys. This organ has more blood flow. In this case, this will lead to the decreased drug distribution. Okay, so let me correct that here. We have organs such as the brain, liver, and the kidneys. These organs considered like rich in blood flow. These organs, these tissue, in this case, the medication will be distributed more highly to this organ. So we can say here, organ which with a rich high blood flow, such as brain, kidney, and liver, they have more drug distribution. So more drug distribution will be maybe moved to the organ rich in blood flow, such as brain, liver, and kidney. However, on the other side, with other organs such as or tissues such as skeletal muscles, skin, and adipose tissue, they have less blood flow. Therefore, we have less drug distribution to this organ. We need to remember what happened during the cardiogenic shock. For example, when you have cardiogenic shock, we have less blood flow. This will lead to the decreased drug distribution. Other factors may affect the drug distribution: capillary permeability. We need to look on the capillary structures, and this capillary structures varies according to the organs. When you look, for example, on the brain, on the liver, on the kidneys, on the intestine, for example, here the basement membrane exposed by slit junction between endothelial cells. This is the normal things. In the liver, we have slit junction. However, when you look on the capillary structure in the brain, we have continuous capillary structures. There is no slit junction there. We have tight junction, and we call this one blood-brain barrier. Okay, before we go further, we have some terminology, medical terminology. Charged mean ionized. We need to familiarize ourselves with this terminology. Charged mean ionized. Hydrophobic mean polar. Lipophilic, easily soluble in the lipid membrane. Tight junction, no space for the medication to cross the membrane easily. Slit junction, we have pores, we have fenestration, allow medication to cross easily. This image here represents the blood-brain barrier, the capillary structure in the blood-brain barrier. On the left side, as you can see here, we have the endothelial cells, the green color. Then we have the basement membrane, the black line. Then we have the pericyte, belong to the neurons. The pericyte, the red color. So you can see green, black, and red color. And you can see the connection between endothelial cells. The connection is very tight, and we can call that tight junction. So we have tight junction among the endothelial cells. Does not allow the medication to leave the blood. Does not allow the medication to leave the blood to the central nervous system. It's not easy to leave the blood to the central nervous system, for example, here. If you look on the other side, on the liver and spleen, you can see the same structure. We have endothelial cells, basement membrane, and pericytes. However, if you look on this one here, we have space. We have slit junction. We have space between the endothelial cells. This space called pores or fenestration allow the medication to cross this through pores to the peripheral tissues. Speaking about the capillary structure of the blood-brain barrier, we mentioned that we have tight junction, does not allow the medication to pass easily. We have two conditions for the medication to pass from the blood to the central nervous system. Number one, the medication need to be high lipid soluble to cross through the membrane, dissolve in the membrane, and cross the membrane. Example, we have thiopental. Thiopental, this medication considered like ultra short, rapid of action for general anesthesia. Another transport system will be like active transport. We have levodopa. Levodopa require carrier active transport to leave the brain, to leave the blood circulation to the brain through the endothelial cells. So we have two main mechanisms: high lipid soluble, example thiopental, or active transport levodopa. But if the medication charge, as you can see, is this medication will not be able to cross the blood-brain barrier. Do we need to understand the short duration of action of hypnosis, sleeping, induced sleeping by thiopental? The answer is yes. Thiopental considered like rapid central nervous system action due to the high lipid solubility and the rapid blood flow. This medication quickly enter the central nervous system and induce anesthesia immediately. So when you prescribe this medication IV, the patient, you can see the patient maybe get involved in sleeping and in the stage of anesthesia. Okay, what happened next? This medication start after a few seconds and remain in the brain for 30 minutes, half an hour. Then the medication will leave the brain by the mechanism called redistribution, will leave the brain to another tissue such as fat and skin and skeletal muscle. We call this process as distribution, slow distribution. So what happened here? The slow distribution of thiopental to the skeletal muscle and adipose tissue lower the concentration on the blood, and this will lead to the decreased concentration of the plasma in the blood, will maybe result in decreased concentration in the nervous system, and the patient will return to the consciousness. So the rapid and short duration of action of thiopental affect largely due to the redistribution from the central nervous system to the other tissue rather than rapid metabolism or excretion. Okay, speaking about the liver, speaking about the liver, spleen, and kidney, small intestine. As you can see here, the capillaries, the structure of the capillary has a slit junction or something called fenestration or pores, and you can see here the name for this one, that we have slit junction or fenestration or pores. This allow the medication. This allow large protein and the drug will easily pass through these pores and increase the drug distribution to these tissues and cells. So when we have this fenestration, the capillary, there is small pores and fenestration that increase permeability of the medication. Okay, for capillary permeability to the medication, in order to enter the brain for the medication, the medication need to be passed through the endothelial cells by mechanism called passive diffusion, and this passive diffusion need to be high lipid soluble such as thiopental, or actively transported such as levodopa. So they remind us here with the central nervous system, the lipid soluble drug readily penetrate the central nervous system because they can dissolve in the membrane of the endothelial cells. However, they said ionized medication or oral medication fail to enter the central nervous system because they are unable to pass the endothelial cells. Binding of drugs to the protein. This is another aspect that affect the drug distribution. Normally, binding drug to the protein is like reversible process, non-selective. This is important for us. So reversible, non-selective binding to the plasma protein mean that will be sequesters the drug and slowing their movement to the bloodstream, out of the bloodstream. So the situation here for binding to the protein will be reversible, non-selective, and sequester drug in the plasma and prevent drugs or slowing drug movement out the bloodstream. It is important to remember that the drug binding to the protein it's important to remember that the drug binding to the protein considered like inactive, and the unbound fraction considered the active form. So we have protein, and then we have medication, then we have the reversible equation, medication plus protein complex, and let me clean this one, complex here, and this one consider like inactive, and the medication here, this is a free, and this is able to move freely through the tissues and practice the effect. So bounding drug to the pharmacologically considered like inactive, free unbound medication considered like the active, and that interact with the target site tissues and trigger biological response. The question here, which part of which the following part of medication will be active? The binding to the protein or the free drug? The free drug will be the active. The free drug will be able to cross the tissues to trigger biological response and eliminated from the glomerular filtration. Example of medication in the clinical practice, we have warfarin, and they try to remind us the warfarin is like considered like anticoagulant, and the warfarin highly bound to the plasma albumin, highly bound to the plasma protein. So the patient come to the clinic is the patient already on warfarin, and the patient suffer from urinary tract infection. The physician, the BA, the nurse place him on sulfonamide as antibiotic, and the brand name for this one like Bactrim. It's like a combination between two medication, Bactrim and sulfamethoxazole trimethoprim. They said the Bactrim have a greater affinity of binding to the albumin, and this will display warfarin from the binding site, and this will increase the free level of warfarin and increase risk of bleeding. So what happened there? I will repeat the concept of combination, the story behind the combination between warfarin and the sulfonamide. The story the story will be like a patient suffer from deep vein thrombosis, and she already treated with warfarin as anticoagulant, and the patient come to the clinic suffer from urinary tract infection. The physician prescribes sulfonamide to the patient. After a few days, the patient starts suffer from bleeding. How do you explain the process here? What happened in this patient? So what happened here? Sulfonamide bind to the protein, displace warfarin from binding to the protein, increase the free fraction of protein, and increase activity of warfarin. So now we have the competition between binding to the protein between sulfonamide and warfarin. Therefore, if the patient take warfarin, we don't recommend to use sulfonamide in this patient because of the competition of binding to the protein. This article here, the title for this article, to try to remind us with the interaction between warfarin and sulfonamide. We have other medication, so you can see if the patient on warfarin and you prescribe sulfonamide to your patient, there is a risk of bleeding. And this will be explained through the competition on the binding protein. Okay, it's very important to understand this image here, this figure, when we prescribe the medication to the patient. When you prescribe the medication to the patient from this image here, this medication absorbed orally to the blood circulation. In the blood circulation, you can see here the medication even to be free drug or binding to the protein, and this like reversible relationship. When we have decreased level of free drug, we are going to have some more release from protein bounding medication. So the free drug, you can see, able to move freely. From the name, free drug move freely. The free drug will go to the site of action, could be the heart, the joint, the eye, the brain. Okay, the free drug go to the site of action. The free drug will undergo a distribution. The free drug will be metabolized. So you can see here that we in the systemic circulation, the drug even to be free or binding to the protein. However, the free drug will be move easily between the tissues and cells. Okay, what is the clinical application of binding drug to the protein? For example, here the first case, we have the liver here. We know that the liver considered like the source of synthesis of plasma proteins such as albumin. And if the patient suffer from liver dysfunction, that means we have reduces the protein synthesis, decrease binding to the protein, and we have increasing level of free drugs. In this case, we have the metabolized drug affect binding and bound balance also. So two things will happen if the patient suffer from liver dysfunction. We have less protein, less albumin. That means we have increasing free drug. We have increasing level of free drugs. This is number one. And also will drug metabolized will be affected. Moving to the other side, other part here, other organ will affect the protein binding will be the kidneys. So, for example, if the patient suffer from nephrotic syndrome or the CKD, in this case, the situation here, the patient unable to eliminate the protein. So, this medication will alter clearance of the medication, especially protein binding drugs. So the situation will be increased concentration of the medication, unable to eliminate. This is number one. And number two, during nephrotic syndrome, the patient will lose a lot of protein. In this case, this will increase free drug in the plasma because we have less protein. Okay, so we have two approaches here. The liver, when you have liver dysfunction, we have less albumin, increase free drug. If we have liver kidney disease such as nephrotic syndrome, we have less protein, we have increased level of free drugs. Moving to the next section in the pharmacokinetic, the third part will be the drug metabolism. Drug metabolism, we already know that the primary side for drug metabolism will be the liver. Even we know that we have some other organ who may be involved in the metabolism, but the liver considered the main organ responsible for metabolism. And we know that also we have some medication considered like prodrug, or like we call this one inactive medication. So we have some medication considered like prodrug and need to be activated. So when you have prodrug here, and this drug arrives to the liver, the liver will activate the medication. So will be the active drug. Prodrug and the liver will be activated to the active form. So what is the normal result of the metabolism? The most commonly occur the inactivation of the medication. Sometimes we have some cases of activate. So, but 90%, let me say, inactive the medication, 10% activate the medication. We have some example. For example, here we have codeine, we have enalapril, and we have morphine. Okay, with the metabolism here, the medication will be converted to the active medication, from active to active medication. Metabolism inactivate, the purpose of metabolism inactivate of the drug. Number two, increase water solubility. Number three, facilitate excretion through the urine and bile. Okay, regarding metabolism of lipophilic drug, normally the liver take the responsibility. Normally the liver take the responsibility to metabolize the lipophilic drugs and make this lipophilic drugs like less lipophilic, and you can see here increase water solubility. Moving to the next slide here. So the medication, the metabolism facilitate elimination, and the lipid soluble maybe goes through the metabolism in the liver through two phases, phase 1 and phase 2. Phase 1 metabolism and phase 2 metabolism. Phase 1 metabolism related to the modification such as hydroxylation, oxidation, hydrolysis. Phase 1 metabolism. Phase 2 metabolism related to the conjugation, binding to the become more water soluble. So the reason for the liver metabolism to prepare the medication to be able to eliminate through the kidneys. So the liver prepare the medication to be eliminated from the kidney. The medication should be water soluble, lipophilic medication. So the kidney cannot efficiently eliminate lipophilic drugs due to their ability to cross cell membrane and reabsorb again in the distal tubules. So the medication should be hydrophilic. So if you go back a little bit to see what happened there with the metabolism increase water solubility, increase drug water solubility. So the purpose of liver metabolism to facilitate elimination of drug undergo metabolism in the liver. Okay, we have two main phases of drug metabolism: phase 1 reaction, phase 2 reaction or metabolism. We have phase 1 and phase 2 reaction. For phase 1 reaction, with this phase 1 reaction, the purpose to modify chemical structure of the drug, we have three main processes: oxidation, reduction, hydrolysis. The outcome here, the purpose of this one, to make the medication more polar, less active metabolite. So with the phase 1 metabolism, we need to remember three main processes: oxidation, reduction, hydrolysis, and mainly involved in the cytochrome B450. Okay, regarding phase 2, this phase 2, the phase 2 metabolism, the medication will be binding to the other group to make it like more water soluble. We have several processes such as glucuronidation, solvation, acetylation. For example, by adding the glucuronic acid, adding sulfate group, or adding acetyl group. And the result will be the medication become more highly water soluble and easier to eliminate through the kidneys. We need to ask ourselves what is the result of drug metabolism. You can see here we have several options for the result of metabolism. The most popular process, the result will be inactivation of medication, inactivate the drug. We have some cases of activation. We have some cases no change happened to the drug. So the most popular case, this is a most popular case. This is a less popular case, and very rare to see no change, for example. The most popular case, inactivation of the medication, the drug will be converted into inactive metabolite. For example, here, lidocaine metabolized in the liver to inactive metabolite and excreted later on. For the medication activated, for example, we have inactive medication prodrug converted to its active form. Example here, codeine considered like active and convert to into the active metabolite called morphine. So you can see here codeine is active, and its metabolite considered like active. Next, we have some cases no change, even with the metabolism. When the drug metabolized, no change happened. The drug remained unchanged and excreted in the original form. So example here we have digoxin. Digoxin excreted largely unchanged in the urine. So we have three cases for the result of drug metabolism. Most popular one, inactivation of the medication, activation of the medication, and no change. This table considered like important table for us because normally we are dealing with the medication, and you can see here we have some medication considered like prodrug or inactive drugs such as azathioprine, cortisone, prednisone, levodopa, zidofudine, enalapril, cyclophosphamide. This medication will be metabolized by the liver to the active metabolite. For example, you can see here that I will go with the enalapril, this medication for blood pressure. This will be activated to the enalaprillate. We have, for example, zidofudine for the HIV, for treatment of AIDS. This medication inactive and should be metabolized by the liver to the zidofudine triphosphate. Moving to the cortisone, very popular medication, cortisone, inactive medication, and this will be metabolized to the hydrocortisone. Prednisone, this will be activated to the prednisolone. Levodopa, the medication for Parkinson's disease, should be activated to the dopamine on the brain. Okay, so now we are talking about the prodrug activated to the or to convert to the active medication. Okay, what happened for the when you have active to active? We have some case, for example, we have codeine, and codeine active medication in the liver. The liver will be metabolize the codeine to the morphine. Okay, morphine active, codeine active. Even with the morphine as active medication, the liver will metabolize the morphine to morphine 6 phosphate, 6 glucuronic phosphate, also considered like active. Another example, important example, diazepam. This is belong to the benzodiazepine group of medication. Diazepam active medication, even the liver will metabolize diazepam to nordiazepam. Okay, this is the second case. The third case, we have the medication, active medication work properly in our body, and very popular medication, Tylenol, acetaminophen, active medication. The liver will be metabolize this medication to another product, another metabolite called N-acetyl benzoquinone, benzoquinoamine, and called NAPQI, and this considered like toxic product. So Tylenol, acetaminophen will be metabolized to the toxic products with a specific amount of Tylenol considered safe. But if you take toxic large doses of Tylenol, Tylenol considered like toxic product. Okay, let us speak about phase 1 metabolism, especially about the cytochrome B450. As you can see here, the major enzyme, major phase enzyme, and this enzyme, cytochrome B450, localized in the smooth endoplasmic reticulum (ER), in the liver, in the GI system, sometimes in the lungs and in the kidneys. Important issue here to remember, cytochrome B450, we have around 75% of the drug metabolized by cytochrome 3A4 and cytochrome 3A5 or 2D6. So the most popular medication, the majority of the medication, 75%, three-quarter of the medication metabolized by 3A4, 3A5 or 2D6. 70, we have 50% of the medication metabolized by 3A4 and 3A5 alone. 3A4 considered like the major isoform and wide substrate range, so the most popular one, 3A4. They found this cytochrome could be inhibited by some medications such as cimetidine, erythromycin, azole. So cytochrome 3A4 could be inhibited by cimetidine, erythromycin, azole, or could be induced, activated by carbamazepine, phenobarbital, phenytoin, rifampicin. Someone may ask, okay, what is this medication for? So cimetidine inhibitor medication inhibit 3A4. Cimetidine considered like histamine H2 blockers and has been used for peptic ulcer disease. Erythromycin inhibits cytochrome 3A4. Erythromycin belong to the macrolide antibiotic. Azole is like a group of medication belong to the anti or antifungal medications such as ketoconazole or fluconazole. So fluconazole, ketoconazole inhibit cytochrome 3A4. For the inducers, carbamazepine, this medication used for epilepsy. Phenobarbital belong to the barbiturate. Phenytoin, medication used for epilepsy. Rifampicin, medication belong to the antibiotic. Okay, so for this here, this slide here, we need to remember which medication inhibit or induce cytochrome 3A4. We have list of medication. Moving to the cytochrome 2D6. Cytochrome 2D6, here they found we have different people, they have different percentage of metabolism. When you speak about, we have some people present fast metabolizer and other people consider like slow metabolizer. So according to the genetic variation, according to the cytochrome 2D6, you can see here we have genetic variation and hydroxylation. So 2D6, for example, two medication inhibited or like inhibit 2d6 or inhibited by 2d6. So what we have here, so we are going to have some people with a fast oscillator, slow oscillator. Keep that in mind. We have two medications such as quinidine, medication used for malaria or like cardiac arrhythmia, and we have haloperidol, this medication used for schizophrenia. We have lectures, entire lecture about antipsychotic. If you need more information about haloperidol, I refer you to the lecture about antipsychotic. Haloperidol is like antipsychotic medication, and quinidine, antiarrhythmic medication, and anti-malaria medication. These two medication inhibit 2d6. So you need to take this in consideration when you prescribe it to your patient. Okay, speaking about the phase 2 metabolism, phase 2 metabolism include the addition of a group, addition subgroup to the drug. This subgroup could be glucuronidated, glucuronate, could be glutathione, could be glycine, sulfate, or methyl group. The most popular one, glucuronidation, the most popular glucuronidation. They found this conjugation activity, glucuronidation, reduced in neonates and increased risk of toxicity in neonates. Regarding acetylation, important maybe clinical aspect for acetylation, they found later on in the practice we have some people consider like fast acetylator, fast metabolizer. We have some people slow metabolizer. For example, you prescribe the medication for the hypertension such as hydralazine. Some people may present with the side effect called systemic lupus syndrome. Systemic lupus syndrome, this is, I've seen that in patient took with slow acetylator metabolizer. Another conjugation example for the medication minoxidil. Minoxidil metabolized through the solvation process. Acetaminophen metabolized through the process called GSH conjugation. GSH conjugation stands for glutathione. So glutathione and GSH the same. What are the differences between metabolism in general and first pass metabolism? Important question in the clinical practice and in clinical pharmacology. Do we need to differentiate between metabolism and first pass metabolism? If you go to the definition here for the metabolism in general, the body chemically alter the drug typically to make it easy to excrete. So you can see here in general the body will modify the medication. This is metabolism. Moving to the first pass metabolism, here the initial step happened in the liver after absorbed and before reaching the systemic circulation. The key word here, the key word we need to remember, metabolism happened before the medication reached to the systemic circulation, mainly happened on the liver. But if you speak about general metabolism, could be happen in the liver, in the kidney, in the lung, in the intestine, or other tissues. What happened here, the purpose of this one here to reduce bioavailability with the first pass metabolism, but for general metabolism to transfer the lipophilic medication to the hydrophilic medication and make the medication easier to eliminate through the urinary system. What we have here for the metabolism, we have phase 1 and phase 2 metabolism. For first pass metabolism, and what we have here, we have the portal vein and we have the different system. Example here, most of the drug for the first pass metabolism. Example for most of the drug for the metabolism, normal metabolism. For the first pass metabolism, here we have nitroglycerin. Nitroglycerin, if you prescribe this medication orally, 90% of the medication will be destroyed in the liver and 10% only will arrive to the blood circulation. Okay, half-life, another important terminology in clinical pharmacology and pharmacokinetic. Half-life, elimination half-life is the time needed to decrease the plasma concentration of a drug to 50% of a formal level. So decrease plasma concentration to the 50% of the plasma level. Okay, 50%. Most of the medication will follow the half-life elimination process, this manner here. The percentage, fixed portion of the medication will be eliminated in a given period of time. Example here, So the half-life definition, the time needed for medication to decrease plasma concentration to 50%. This is a half-life example for us. Drugs such as acetaminophen, Tylenol, half-life 2 hours, indicated that in each 2 hour the medication period, the 50% of the medication will remain in the body. So what that mean here? If you look on the graph here, we have the acetaminophen concentration, and then we have time and the half-life of this medication, 2 hours. So after 2 hours, 50% will be remain in our body. So you can see here we have, let me say, we have 100 milligram in 100% of acetaminophen in our body. After first half-life, after the first 2 hours, 50% we are going to have in our body. After 2 half-life, we are going to have 25% in our body. After maybe 3 half-life, this is the first half-life here, the second half-life. After third half-life will be like more than around like roughly around 80 or 90% of the medication will be eliminated. So between the 3 to 4 half-life or 4 to 5 half-life will be eliminated from our body. What is the clinical application on the change in half-life here? Patients who may have increase in half-life include those with a decreased renal or hepatic flow, decreased metabolism, increased risk of drug interaction. So the medication will remain in the blood for long term if you have decreased renal function or hepatic blood flow. If you have decreased metabolism, these patients may require decreased dosage or less frequently dosing interval. Okay, I would like to emphasize here an important issue about renal function or hepatic function. If the patient suffers from decreased renal function, renal impairment, or hepatic impairment, this will increase half-life of the medication. If the patient suffers from decreased metabolism, such as hepatic cirrhosis, all these may increase the half-life of the medication. Okay, the case here, we have 63-year-old woman with a history of renal disease and currently on the dialysis, is brought to the emergency department due to the seizures after receiving an intravenous infusion of anti-seizure drug X. Which outcome is most likely to occur in this patient? Number one, increase half-life, decrease half-life, increase half-life, increase half-life, no change in half-life. This one is not correct, because we are going to see change in half-life. We are not going to see decrease in half-life. This could be correct, this could be correct, this could be correct, increase half-life. All these could be correct. For example, let me clean this one. So this one could be correct, increase half-life, increase half-life, increase half-life. Okay, what happened here? When you have increased half-life, that means we have increased activity. Okay, so how we can manage here? Do we need to increase the dose? Yes or no? No, we are not going to increase the dose because we have increased half-life. Are you going to do nothing? No, we need to adjust. What we are going to do, we are going to adjust the dose. So the correct answer will be D. The patient may suffer from increased half-life of the medication. We need to adjust the dose, decrease the dose in order to make it applicable to the patient. Okay, speaking about first pass metabolism, pharmacokinetic, the next important concept for us, first order elimination. We already have the definition of half-life. They said most of the medication follow the first order elimination. What that mean? We have characteristic of half-life elimination. Most of the medication follow the half-life elimination process, which mean that proportion of the medication will be eliminated through our body every time. So for example, we have half-life, 2 hours half-life for the acetaminophen, that will decrease concentration of the medication by 50%. So you can see the rate of elimination is proportional to the concentration of the medication. That means the concentration of the drug in the blood will decrease 50% for every half-life. This most of the drug will follow in the clinical practice, follow the first order kinetic. Okay, regarding zero order kinetic, there if you go back, we have fixed proportion. We have percentage of medication. 50% will be eliminated every half-life. Speaking about zero order elimination, we have constant amount will be eliminated through the fixed amount of time. For example, we have aspirin, phenytoin, ethanol. For example, every 2 hours we have specific amount. Here we don't have proportion or fraction or percentage. Here we have amount of medication will be eliminated every specific amount of time. So three medication present this elimination, this process of elimination, zero order: ethanol, phenytoin, and aspirin. Okay, moving to the next important topic, steady state concentration, CSS, steady state concentration. We ask ourselves, how much time do you need to take the medication to arrive to the steady state concentration? If you look on the, for example, we have zero concentration of the medication before you start, then the medication start increase with the repeated dose, and after 4 half-life, the medication will, after 4 to 5 half-life, the medication will arrive to the steady state concentration. So depends here what we have for steady state concentration depends on the elimination half-life of the drug. Clinical steady state reach after 4 to 5 half-life. So they try to remind us, you prescribe repeated dose here. You prescribe repeated dose to the patient, repeated doses. Okay, first half-life we have 50%. You prescribe another dose, we have after 90%, 3.5 half-life, 97%, 94, 97% after 4 to half-life. So this is a case of a clinical case study, clinical steady state. So the medication will arrive to the 95 roughly, or 94, 97% rate of elimination. Here what we have in CSS, the rate of elimination will be equal to the rate of administration. We have some example here, and we have maybe a figure here to show you, then we go to the example. So what we have here, when we prescribe the medication to the patient, prescribe the medication, let me say you prescribe 100 milligram, which is represent 100%, for example. After first half-life, we have 50% remaining, 50% remaining in our body, and 50% will be eliminated. After second half-life, okay, 75% will be eliminated, and 25 will be remain in our body, remain and eliminated. After third half-life, 87 will be eliminated, 12.5 will be remaining. For half-life, 93% will be eliminated, 6.5, 6.2 will be remaining. After 5 half-life, 97 will be eliminated, 3% will be remaining. So we can say that between 4 to 5 half-life, most of the medication will be eliminated from our body between 94 to 90, between 94 to, I will repeat that, write it here, between 94 to the 97% will be eliminated from our body after 4 to 5 half-life. Go to the example here. Important example here, we need to remember what we have here. When you prescribe only single dose to the patient, the blue one, single dose of a drug, reduce a single peak. We have reduced a single peak of the plasma concentration, and then we can see here we have peak, we have single peak, and then decrease concentration to the zero after 4 half-life or 5 half-life. So single dose, we have peak, then decrease. Okay, what happened after repeated administration? The drug can lead to the fluctuation, accumulation. So you can see here first half-life, second half-life, third half-life, fourth, fifth, and we have steady state. So what that mean here, if you look on if you draw a line here, then another line here. Okay, you can see here we have a steady state of the medication. We are remaining in this one here, for example, steady state. So after 4 to 5 half-life, the drug will achieve the steady state concentration. I will go to the example here. We have medication called tinoxicam, non-steroidal anti-inflammatory medication, and this medication used for the treatment or management of arthritis. Half-life for this medication 72 hours. The question now, how much time need to achieve the plasma concentration. So we take the half-life, multiply by 5, with half-life 72, multiply by 5, 360 hours. This is equal to the 15 days, around 2 weeks time. So if you have patient come to the clinic, suffer from arthritis, you prescribe tenoxicam to your patient, tenoxicam, and when you prescribe to your patient, ask the patient to come back to the clinic for the follow up. So the reason, after 2 weeks time, you can see here the medication need 15 days to show the steady state concentration and to show the efficacy. Okay, so here we have a important example about medication, about warfarin. Do we know that warfarin is like medication? We know the warfarin like anticoagulant medication, and warfarin requires therapeutic drug monitoring, TDM. Warfarin require TDM. If you prescribe warfarin like single dose, you can see here we have the peak, then we have decrease to the zero, and now we don't use it because this one should be long-term treatment, weeks, months, and years of treatment with warfarin to prevent deep vein thrombosis or treatment of deep vein thrombosis. Okay, what happened if you prescribe like frequent doses? We prescribe first dose, this is the first dose, second dose, third dose, and so on. They said after 10 days roughly of treatment with warfarin, warfarin will arrive to the steady state. So this is important here. So that maybe we can tell ourselves we need 10 days to arrive to the steady state concentration with the treatment or with the warfarin. However, we cannot wait for 10 days. So the patient come to the clinic suffer from deep vein thrombosis or from the pulmonary embolism, and you place the patient on warfarin. We are not going to tell the patient this medication will start working after 10 days because the patient may die from pulmonary embolism. For this reason here, we need to do something called like loading dose. So we have, when we talk about loading dose, you can see here the loading dose with this one here. Loading dose, okay, we prescribe 10 milligram to the patient, lead to the jump in the concentration, 10 milligram of the on day one, 10 milligram as a loading dose. Then we follow in 1 milligram daily. So start with the 10 milligram loading dose, followed by 1 milligram daily. In this case, you can see here after 1 to 2 days, we arrive to the steady state concentration of warfarin. And this explains why we use a loading dose for the patient before we place the patient on the maintenance dose. Okay, in the previous section, we discussed the absorption, we discussed the distribution, we discussed the metabolism, protein binding to the medication, we discussed the capillary permeability, blood-brain barrier, the liver and spleen, and intestine barrier, biological membrane, how the medication can cross the membrane. The last part of the pharmacokinetic will be drug elimination. Okay, regarding drug elimination mean removal of the drug from the body that may occur few number of route of important organ, but the kidney considered one of the most important organ of elimination. So the kidney is the most important organ responsible for drug elimination. We have some other organs and tissue responsible for elimination, such as bile, intestine, lung, milk, or during lactation. What happened here, if you look on the drug elimination, we have three main process. We have the glomerular filtration, we have proximal tubular secretion, we have distal tubular reabsorption. So here we are speaking about three main process of drug elimination from the body. If you look on the graph on the right side, you can see here the medication come with the blood here. So we have drug coming with the blood, and this drug will be filtrated through the glomerular apparatus, through the proximal convoluted tubule, to the loop of Henle, to the distal tubule, and then we'll collecting that to the urine. Okay, regarding drug elimination, we have the nephron here, and nephron considered like the main unit of elimination, and the kidneys. Five more main part. We have the glomerular apparatus, proximal tubule, lobe of Henle, distal tubules, and collecting ducts. As you can see here, in the glomerular filtratus, the medication should be free to enter the glomerular filtration. And the distal tubules, the medication follow the active secretion, and this active secretion has a non-specific carrier. Moving to the distal tubules, the medication follow the process called passive reabsorption, and at the end, the medication will be eliminated through the urine. Okay, we have conditions here for the medication to enter the nephron from the blood through the glomerular filtratus apparatus. The medication should be free to enter the glomerular filtration. Regarding the active secretion, the medication will be transported through the non-specific carrier through the proximal tubules. Moving to the passive reabsorption from the distal tubules, the medication should be lipophilic and unionized. Okay, regarding the drug elimination, we have three processes: glomerular filtration, proximal convoluted, proximal tubular secretion, distal tubular reabsorption. Regarding the glomerular filtration, the drug delivered to the kidneys. Number one, the drug should be unbound free to pass through the capillary of Bowman space. There is no effect of the lipid or solubility or pH here. What we need only the drug to be free and able to pass through the Bowman capsule. This is the first condition for the drug elimination. Glomerular filtration, the drug need to be free and bound without maybe effect of pH or lipid solubility. Moving to the second one, the second part of mechanism of elimination, proximal tubular secretion here. We have two energy requirement for the active transport, two energy. We have one transport system responsible for weak acid transport, and another one responsible for weak base transport. So normally what we eliminated there, we eliminate the charged ions. So eliminated the charged ion, deprotonated form A minus for the weak acid and BH plus for the weak base. So the active secretion here, we have non-specific carrier, two energy required, non-specific carrier, one for acid and one for bases. The last part of the elimination in the kidney, in the nephron, the distal tubular reabsorption. So from the name here, reabsorption, that means the medication will come back from the urine. The medication will come back from the urine to the blood. And this happened in the distal tubules. We have some condition here. The first one, the drug need to be uncharged. So in order to pass from back to the circulation, number one. So number one need to be uncharged. Okay, what happened here? We know that we can change the urine of pH. If we change the urine of the pH, this will ionize the medication. So if you have alkaline medication and you make the urine acid, and this will be lead to the charged the medication and enhance elimination. Okay, so in this case we can manipulate the pH of urine and enhance clearance, and we have some example later on. Okay, clinical application for the proximal tubular secretion, and this is active. We are speaking about active secretion. And we have two transport system, one for the weak acid protonated and one for weak bases protonated. The example here, clear example, we have amoxicillin and probenecid. So the patient, we have scenario here, case study. The patient is administered amoxicillin and probenecid simultaneously. The mechanism of action here, they found probenecid compete with the amoxicillin for the same renal transporter responsible for drug elimination. The outcome of this combination, this will lead to the decreased renal excretion of amoxicillin and higher and prolonged concentration of amoxicillin. This kind of interaction considered like useful interaction, benefit interaction. So now we can imagine the case. The patient suffers from gout or hyperuricemia, hyperuric acid, and the patient is treated with a probenecid. Okay, the patient come to the clinic to do the respiratory tract infection, and you prescribe amoxicillin to your patient. So what is your expectation here? The amoxicillin will remain high in the blood due to this combination between probenecid and amoxicillin, or amoxicillin will be increased excretion, or remain high in the blood, high concentration, or no change. So if you said the amoxicillin will be prolonged and increased concentration in the blood, you are correct, because the amoxicillin will be compete with the probenecid on the elimination, on the active transport. Okay, again, we have it here. We have the competition between amoxicillin and probenecid on the active secretion through the proximal tubule. Okay, last part of the elimination, we have distal tubular reabsorption. Distal tubular reabsorption, last part, distal tubular reabsorption. We have phenobarbital. We know that phenobarbital belong to the barbiturates. This medication could be used for epilepsy and as a hypnotic. Very rare to use currently. Phenobarbital. They found that overdose of phenobarbital could be lethal. So if you have patient come to the clinic with the toxicity of phenobarbital, we can treat this patient with a prescription of barbiturate, treating this patient by given bicarbonate. Bicarbonate lead to alkalinize the urine, and this will ionize the phenobarbital and decrease reabsorption. So this will give us the impression that phenobarbital is considered like acidic drug. So phenobarbital acidic drug, if you alkaline the urine, and this will lead to phenobarbital to become charged and eliminated through the urine. Okay, this explains how to treat patient. This is type of toxicology treatment. Okay, manipulation of BH urine. If you have weak base, we go the acidification of urine by ammonium chloride. This will lead to the proteination and ion trapping. For example, if you have overdose of aspirin, and we know that aspirin is considered like acidic drug. So if you alkaline the urine by prescribing bicarbonate, this will lead to the charged and enhanced excretion. If you have acidic drugs, this will lead to the acidic drugs, and if you have alkaline drugs, weak acid alkaline drugs, and you acidify the urine, you protonated and enhance of elimination of this medication. Okay, I will give you another example for weak base, and we have it already on some places here. For the weak base, for example, we have lidocaine. I will go back. We have lidocaine, codeine, tramadol, amphetamine, diphenhydramine, cimetidine. So all these considered like weak base. So if we have large doses of this medication, amphetamine, for example, very popular, important medication, diphenhydramine, Benadryl, cimetidine. If we have overdose from this medication, I will go back to the previous slide. If we have overdose, we can prescribe ammonium chloride or ammonium chloride, and this will be protonated of amphetamine, for example here, protonated of amphetamine and enhanced excretion of amphetamine. And this is kind of toxicology treatment for the patient, how to manipulate pH of urine. Again, moving to the last part here, as you can see here, ion trapping happened in the passive reabsorption that will lead to enhanced medication excretion. And medication should be lipid insoluble and ionized charged. Okay, this will conclude our lecture for today. We discussed the pharmacokinetic and clinical aspect approach. We already discussed the absorption, metabolism, elimination, distribution, phase 1, phase 2 metabolism, distribution of the medication, protein binding, the possibility of drug-drug interaction. We discussed as different type of drug elimination. I hope you enjoy this session, this lecture about pharmacokinetic. As we mentioned in the beginning, pharmacokinetic considered the first chapter in clinical pharmacology and drug therapy. It's very important to understand this concept in order to apply the knowledge you are going to gain after all when you learn the another topics in clinical pharmacology. Okay, this will conclude our session, our lecture for today. Thank you so much for your watching and have a great day, everyone.